Hello, my name is Fátima Rodriguez, and I'm a professor of medicine at Stanford University and the chief of preventive cardiology here. I also was honored to serve as vice chair of the CKM guidelines that were just published. Thank you for that question. This guideline explicitly focused on addressing health disparities and health inequalities as part of how you assess and define CKM categories. We know that historically marginalized populations have a disproportionate burden of cardiometabolic risk factors, but often those are diagnosed later when they're progressed to higher stages. So, what we hope to do in this guideline is again to start early, really focus upstream on the social drivers of health so that people don't progress as frequently to the higher CKM stages. We explicitly have recommendations on routinely screening for adverse social drivers of health that can impact how individuals experience cardiometabolic disease. We provide details on validated tools and scales that can be used in clinical settings to do this routinely. And when these adverse social determinants of health are identified, we then recommend actually taking action on them and to navigate those barriers to help our patients reach their health goals. But routinely, of course, is challenging to add this to already a busy clinical encounter. And that's something that needs to be intentional. And by making this just part of the clinical conversation and encounter, just as we're screening for obesity, it becomes a lot more routine and less of an uncomfortable questions for both patients and their clinicians. So the prevent equations really are an enhancement from our prior way that we assess risk, which the pool cohort equations. These are specifically a race-free equation. They're sex-specific, but they contain, as you mentioned, other factors that were not part of our prior risk prediction equations, including hemoglobin A1C, kidney function, and an optional social deprivation index. So I think there is some enhancement in that we removed race as a proxy of a lot of the social determinants of health and now more explicitly focus on the risk factors, the cardiometabolic risk factors. The other enhancement of these guidelines is that instead of just focusing on a 10-year horizon, we know that patients obviously experience risk over time. So now for younger adults, we can start early and really think about a 30-year horizon for risk. Additionally, there's a focus on total cardiovascular disease burden, not just on ASCVD, even though there are separate equations for ASCVD and heart failure, because again, we know the risks can vary. This is a topic near and dear to my heart since I'm here in Silicon Valley, where we see the tremendous power and opportunities that technology can give us. But it has to be intentional. So, one real valuable tool that we can have with technology is that it can help us screen opportunistically for disease. I've done a lot of work looking at opportunistic screening with artificial intelligence for atherosclerotic disease. And that can really help us identify people who may not come to care specifically seeking preventive interventions. You mentioned telehealth. So telehealth, incredibly valuable really to extend reach. And we actually have some recommendations in the guidelines specifically if you can't have face-to-face conversations, that it's really valuable to use digital health apps and interventions, particularly around weight loss and cardiometabolic prevention. But I think you really need to be intentional in the design of the technology, make sure you're validating the performance across subgroups, and that we're monitoring carefully that the intended intervention really functions well across all populations. I think the other really important point for our pharmacy colleagues is that we have now these tremendous medications that can have multi-system benefits. So not just for cardiovascular disease, but also for diabetes, for kidney disease. And it is very important that we have these interventions work for everybody. And there are, of course, a lot of issues around access, understanding indications. And I think our pharmacy colleagues really play such a major role in helping close these gaps when we have evidence for therapies that work well.